Hello, this is Dr. Scott Worden, the TOS guy, and today Vanguard Specialty Imaging presents a very special guest, me, one of my favorite guests. I hope I'm going to bring you some new and interesting information about anatomy. We talk about anatomy frequently, and today I'm going to focus on one small area of anatomy and do it in some detail. So, if we're ready to go, I'm going to get my presentation going, and let's get started on TOS anatomy. Anatomy of TOS, the forgotten space. Normally, when we describe the anatomy of TOS, we talk about three tunnels, and then there are three critical structures that pass through these tunnels to go from the chest and the neck through the thoracic outlet to reach the arm. Now, today I'm going to add a new one, the forgotten space, and it may seem like a bit detailed and a bit peripheral at first, but it'll make more sense by the end of the talk. I hope you stay with us. So the three classically described tunnels are, first of all, the nerves leave the neck and they enter the scalene triangle between the anterior and middle scalene muscles and the first rib. Then these structures pass over the first rib through the costoclavicular interval, costo meaning rib, clavicular meaning clavicle or collarbone. And finally, they enter what's called the retropectoralis space, or the space behind the pectoralis minor. So these are the three classically described tunnels. There are some variants on these, but we're going to stick with this model for now. Now we have three critical structures, as you all know likely, that pass through each thoracic outlet. We have the big bundle of nerves called the brachial plexus. We've got the subclavian artery, and we've got the subclavian vein. And which of these structures is affected by compression or tension decides what kind of TOS you have, if not multiple types. All right, so let's just review some of our basic anatomy with some beautiful drawings that I've gotten through the work of some great medical illustrators. This is obviously a frontal view of the thoracic outlet on the left side of the patient. The anterior scalene muscle, which I've talked about a few months ago as being the key to the anatomy, the middle scalene muscle, and then we've got our two bones, the clavicle or the collarbone, and the first rib. All right, look closely at that anterior scalene if you would. It starts from several of these small transverse processes of the spine. That's the cervical spine in your neck. And this bundles all pass together, join together, and they insert on the first rib. Now, this is an example of the scalene triangle, as best I can draw it in this two-dimensional drawing. That's the space between the anterior scalene muscle in the front, the middle scalene muscle in the back, and the first rib at the base. It forms a triangle. We can see that the brachial plexus and the subclavian artery pass through that space.
Hey, Scott.
Yes.
Sorry to interrupt, but your presentation's not showing.
All right.
Or it's not rolling through the slides.
All right. We can fix that. Stop screen. Present. Share screen. And let me know if this is going to work now. How do we look?
You're good.
All right. So I'm going to go back at least to the drawing, and we will get caught up to where we were before. There we go. So we're going to start with the anterior scalene again. Look at where the brachial plexus and subclavian artery come through. And the subclavian vein takes a slightly different course in front of the anterior scalene muscle. Now let's take a look from the side. Here again, we have the anterior scalene muscle. And again, I stress for everybody that learning this anatomy is a lot easier if you just start with the anterior scalene. Once you identify that, everything else falls in relationship to the anterior scalene. And what we've done here is superimpose the triangle, the scalene triangle, to show the anterior scalene is the front wall, the middle scalene is the back wall, and the base of the first rib forms the floor of the scalene triangle. You'll notice that the subclavian artery and the brachial plexus come through the scalene triangle. And then the subclavian vein, which does not go through the scalene triangle, joins those other structures as they pass over the first rib. And this oval, this purple oval, shows the costoclavicular interval. space between the collarbone, clavicle, and the first rib. And of course, the collarbone, the clavicle is quite mobile depending on which position your arm is in. Now, if we go out a little bit further, we get one more classically defined tunnel or space, the retropectoralis space. We start with the pec minor, the pectoralis minor. It originates from ribs, usually 3, 4, and 5, and they join together and they insert on this bony process called the coracoid process. It's not separately labeled here, but it's part of the scapula. So you can see where that muscle attaches. And then you see this purple arrow coming through behind the pec minor. I'm going to go back and reanimate here. You'll see a purple arrow at the top, goes behind that muscle. That is the retropectoralis space. And the circle shows that all three of those vital structures, the brachial plexus, the subclavian artery, and the subclavian vein, go through this space. Okay, so we've got the scalene triangle. We head a little bit laterally, and we get to the costoclavicular interval. Then we head a little bit more laterally. We get the retropectoralis space. And after this, we enter the shoulder or the upper arm. Okay, again, a reminder, we see all three of the vital structures coming through the retropectoralis space. Now we're going to take a look again from the side, the lateral view, and we're going to see that there's this space bounded by the purple box here. And this contains the subclavian vein. I briefly mentioned before that the subclavian vein does not go through the scalene triangle, but here it is in front of the anterior scalene muscle, or pre-scalene, the pre-scalene space. And this is a slightly complicated space that has a lot of importance to patients with various types of TOS. So we're going to discuss it today. This is the forgotten space. Here we can see the collarbone and the first rib as the bony landmarks. The collarbone is the roof of this space. The first rib is the floor of the space. And you'll see the subclavian vein goes through the pre-scalene space. The anterior scalene muscle is at the back of the space. We're going to look at it in more detail. First, let's go to the frontal view. And again, we're going to put this little purple box around the space that the subclavian vein goes through. It's in front of the anterior scalene muscle, and it's between the collarbone and the rib. This is the pre-scalene space. Again, the labels show the clavicle as the roof, the first rib as the floor, and the subclavian vein going through that space. The back margin of the pre-scalene space is obviously the anterior scalene muscle. All right, here's some bony anatomy. We see the clavicle, the collarbone, as it comes up and joins the sternum or the breastbone. So we get a sternoclavicular joint. And then an important structure is this costoclavicular ligament. Costo meaning rib, clavicular meaning clavicle. And so we get this ligament of various sizes and shapes that starts on the first rib and inserts on the very medial or forward portion of the collarbone. Here's just another picture of it reversed. You'll see the text looks reversed here, but this is merely to show another example of the costoclavicular ligament starting on the first rib and going up to the medial aspect of the collarbone. Now, there's another important structure in here called the subclavius muscle. This rides just underneath the collarbone. So, in fact, the roof of this space, the roof of the pre-scalene space, is partly bone, the collarbone, and it's partly soft tissue, the subclavius muscle. If you look just under the subclavius muscle, just to the left of the purple arrow, you see a small piece of the first rib. Now, this has left out the subclavian vein, but we'll get to that soon. Let's take a look on MRI what these might look like. This kind of MRI image is called a sagittal image. At the top is a part of the head. The neck isn't quite here, but it would be coming down from the head towards the shoulder. And we're seeing sort of the shoulder and the upper chest here. The patient's chin would be pointing towards our left. The breastbone or sternum is pointing to the left as well. And we can see here there's a subclavian vein, this black space where blood is flowing. You don't see the blood flowing, you just see a black space on this type of technique. And then you see this band called the costoclavicular ligament. Goes from the first rib upwards and joins the collarbone. And the collarbone goes over the top of the subclavian vein. Here's another image just a little farther laterally. And again, we can see the subclavian vein. Just behind it, to the right, is the subclavian artery. And we see the tendon of the subclavius muscle. And if you follow that tendon towards the right, you'll see it flows underneath the collarbone, which are those two parallel black lines with a white center. Okay, so we've seen the costoclavicular ligament, and we've seen the subclavius tendon. And these are at the anterior or front part of the prescalene space. And they are variable in size, certainly different in different patients. They're also mobile. They move with movement of the collarbone. Now here's a beautiful drawing that we had done recently. Again, we're going to show you the subclavian vein, and we're going to show you how the anterior scalene muscle now forms the back margin of this prescalene space. I think most people can see the collarbone pretty easily, and tucked underneath it, the subclavius muscle and its tendon, and then below the subclavian vein is the first rib. Take a look a little bit to the right, and you'll see the scalene triangle with the artery in red and the brachial plexus going through it. And you can imagine how these spaces are close, but they're not the same space, and they're affected by different structures. That's why it's important to know and understand the prescalene space. What happens when this space gets too narrow? Well, we can see the subclavian vein can get compressed. And as I tell most people, the arteries are thicker muscular walls because they handle higher pressure. The veins handle much lower pressure, so they don't have to be thick or have a muscular wall. So they're much more easy to compress because of the low pressure and because they just don't have a thick muscular wall. And in this case, what's happening is the collarbone comes down. You could imagine the costoclavicular ligament or the tendon of the subclavius could be compressing this vein. All right. And again, the anterior scalene is the back margin of the prescalene space. So what does this look like on MRI? This is a similar sagittal image. We can see quite clearly the subclavian vein. And now this is what happens when the patient raises their arm. This is the subclavian vein. And you can see, in this case, I'm not sure whether it's the tendon or the ligament, but clearly it's compressing that. So let's go back and take a look. This is with the arms down. By the patient's side, we see the subclavian vein nice and round. And now this is with the patient's arms up. And we see the subclavian vein is severely flattened, and that prevents blood from flowing easily from the arm back into the chest. Now, this is what's called an axial image. It's a slice through the patient like a loaf of bread. And you'll see the shoulders off to the side. The patient is laying on their back. So the top part would be their front chest wall. Here's a subclavian vein with the patient's arms down. And when they raise their arms, we're going to see what happens to the subclavian vein, but it comes to a nice tight peak right there because it's severely compressed. One more time, just make this easier to see. Subclavian vein is black because of blood flow. The arms are down. Now when the patient's arms are up, we're going to see that subclavian vein is compressed severely in this case. So we discussed the three tunnels. The classically defined tunnels are the scalene triangle, the costoclavicular interval, and the retropectoralis space. And we talked about three critical structures: the brachial plexus or the nerves, the subclavian artery, and the subclavian vein. Okay, but the difference was that the scalene triangle contains only two out of those three. The costoclavicular interval and the retropectoralis space include all three structures. But that first space, the scalene triangle, does not include the subclavian vein. So what happens is we get this forgotten space, the prescalene space, with different borders and different mechanisms of compression. All right, I'm going to exit this, and briefly what I'm going to do is I'm going to talk about what happens when you compress the vein. So this has been a subject of some controversy, but it's actually quite fascinating. First of all, we define venous TOS in almost all cases by the presence of a blood clot in the subclavian vein. And that's pretty obvious. You get a blood clot and it blocks the flow coming back from the arm. In many cases, patients will show up with a dusky or purple blue looking arm, and the arm is swollen and the arm feels heavy and painful. And it's pretty easy for docs to do an ultrasound and find that blood clot up here. That's venous thoracic outlet syndrome. Although in the past there has been another type of venous TOS described, and that was where the veins would get compressed in certain arm positions enough to block blood flow and create the same symptoms. But that did not involve a blood clot. In most cases, people don't talk about that other case, but a few docs do. We had a guest a few weeks ago, Yingwei Lum from Johns Hopkins, and he knew about the syndrome, and we discussed it in some length. So go back and see Yingwei Lum's talk, and you'll see some more information about that syndrome. However, there's evidence from a lot of animal studies and some human studies that if you compress a vein, a significant vein like the subclavian vein, or the jugular veins that drain the head and neck, that you can get a slow buildup of fluid, what's called congestion by many people, and that can affect those structures that are not draining easily. So some people believe there are mental cerebral symptoms if the jugular veins do not drain correctly from the skull base down to the chest. Might get blocked up here, they might get blocked by a valve down here. And in TOS, we've seen definitely some evidence that if you block those veins, that you can get what's called a congestive neuropathy, where the buildup of fluid over time affects the nerves at a microscopic level. So they get damaged slowly but steadily. So we're paying a lot more attention to this pre-scaling space right now. One of our previous guests, Dr. Farid Gargazlu, spends a lot of time trying to free up the veins. He pays more attention to those than he does to mechanical compression of the artery or the nerves, because of a lot of research that he's done showing what happens when you address the veins primarily. So the pre-scaling space, in short, is a different part of the thoracic outlet. It's got different margins, and it has a different kind of outcome when you compress the subclavian vein. And it's just the subclavian vein. So sometimes patients show up with venous symptoms only because the artery and the plexus are not compressed, but the vein is compressed. And with that, I'm going to stop here with this interesting sidelight about anatomy, and we're going to take some questions, Herb. Main focus: how is neurogenic thoracic outlet syndrome related to a cumulative trauma injury of the cervical spine? And I believe you also asked about cumulative trauma of the upper extremities. So without more detail, I'm going to be a little bit gray about this. I can't be as black and white unless you clarify the question. First thing is, we often try to separate cervical spine related neurogenic pain from thoracic outlet neurogenic pain, because the site of compression of the nerves is important to understand so it can be treated. If it requires surgery, we go to the spot where the nerves are compressed. When you have cervical disc disease or cervical degenerative joint disease, those commonly lead over time to compression of either the spinal cord or to the nerves that exit the cervical spine. So in adults, excuse me, who are, let's say, 50 years or older, we start to see degenerative changes much more frequently. The common age of thoracic outlet syndrome is younger than 50. So it's not usually a challenge anatomically to tell the difference. Now, when you get to cumulative trauma of the upper extremities, cumulative trauma could result from multiple athletic injuries. That could be different than somebody who works in a non-ergonomic workstation and has cumulative trauma, low-grade type of trauma, but it's cumulative and repetitive. That's where we get repetitive stress injury. And in many cases, repetitive stress injury can change the tone of the muscles because they get tight and spastic if you're doing the same thing for 8 hours in a row. And when those muscles get tight and spastic, they change the posture of the neck and the head and the shoulder girdle. For example, the pectoralis minor in the chest, if that's too tight, that can pull the scapula, shoulder blade, forward and down, and that changes the whole balance of the shoulder and changes the position of the collarbone because the collarbone's attached to the shoulder blade. So pec minor syndrome that people talk about They talk, surgeons talk a lot about how it's the space behind the pec minor, the retropectoralis space that we showed here, that space gets too narrow and that's compressing the nerves. But in fact, I think there's plenty of literature showing that that's pretty unusual. And more likely, there are some issues with tension of that muscle, changing the position of the shoulder blade and collarbone, and also uh, putting tension potentially on the brachial plexus because that coracoid process, that little bony hook where the pec minor attaches, can be pulled down onto the brachial plexus. So there's still some understanding of the pec minor syndrome. But to go back to the original question, you can easily, from overuse of the pec minor, you can change the tension in that muscle. The anterior scalene is a frequent target of this repetitive stress, and the upper trapezius muscle is a frequent target of this repetitive stress. So patients may have syndromes where they get periscapular pain between their shoulder blades, or neck pain, or pain out here by the pec minor, and a good doc will palpate and press directly on different spots to find out where the muscles are tight. So I hope that answers your question, and if not, please ask again with more detail. Isabel Soares. Hi, Isabel. Is arterial thoracic outlet syndrome commonly caused by compression of the pectoralis minor muscle? That's great. You led me right into that. So arterial thoracic outlet syndrome is quite rare. It's where we usually talk about the artery is repetitively compressed and the blood flow through it creates a serious vortex that damages the wall of the artery just distal to the point of compression. And if it's just the right velocity, the right harmonics, it can damage that wall and the artery can swell up or form an aneurysm where it becomes bigger like a balloon. Or rarely you can get a stenosis or web or fibrous narrowing. In either case, it puts the patient at risk of developing a blood clot, let's say in the aneurysm. That blood clot can form an obstruction right there, which would be a serious surgical emergency, or the blood clot can break off and go down and lodge in the smaller arteries of the arm, which is usually a surgical emergency as well. Surgeons want to keep the blood flow going to the arm, and they'll go in and remove that thrombus or blood clot pretty promptly. But arterial TOS is very rare. It's about 1% of all cases of TOS. And there is nothing in the literature, to best of my knowledge, that implicates the pec minor muscle or pectoralis minor syndrome in the development of arterial TOS. One more thing I'll add is that there are some variants of arterial TOS. There's a pretty famous pitcher who developed a very small aneurysm at an artery out here called the circumflex humeral artery. There's two of them, and by the name circumflex, they circum or go around the proximal upper arm bone, the humerus. And so where these little arteries branch off, they are a little bit weaker. And in pitchers, we've seen this rarely, but occasionally, that they get these aneurysms there. So that had to be repaired. It's a type of arterial TOS, but even though it's close to the pec minor, I don't think it's associated with it. Much more likely it's associated with the cocking position of the arm, the extreme stress that a major league pitcher would go through. So thank you for the question, Isabel. Hey, you look familiar. Isabel again says, I have thoracic outlet syndrome due to muscular impingement, compression by the pec minor of the artery. I would like to know about doctors in Brazil with expertise in a case like mine. So first thing, I'll ask you to go to our website, www.tosmri.com, and contact us so we can discuss your case privately and securely. The pec minor muscle, some people believe it can compress the artery or the vein. I can say that's really rare in my thousands of cases and in my knowledge of the literature. I think it's pretty rare. I think that it is a spot where you can get an artifact that I'm aware of, that it looks like the artery is being compressed. So we'd want to be sure, and we want to know which arm positions it's compressed in. We want to know how the artery looks in general. This is just broad general information. I'm not treating your case in specific here on the public internet, but please reach out to us and let us try to help you privately. I'm also going to ask people right now, please hit the like button. Hit the little bell that says you want to be notified every time we do a new live stream or other video. And that's really the best way to help us drive the growth of this channel. We're doing this for awareness and education. We want to spread the word so more people can find TOS, because nobody hits Google and says, yeah, I have neck pain, I'd better search thoracic outlet syndrome. That's one of the battles we have. So help other patients, hit the like button, subscribe to us, and also find us on social media like Instagram and Facebook. We are TOS MRI, and reach out to us and support us. Thank you. All right. James Shepard, hi. Could you speak about what anatomically is happening that would contribute to a ringing or swooshing sound in the ears due to TOS? So, tinnitus. It's interesting that you bring this up because, well, my focus certainly is not tinnitus. It can often be associated with abnormalities of blood flow. So there are small arteries around the brainstem that can go into what's called the internal auditory canal. And they can penetrate a tiny bit, or they can penetrate way inside with a very thin artery that loops deeply into that canal. And some of those patients can get what's called pulsatile tinnitus. There are some other causes as well, but they'll get ringing or buzzing or sounds in their ears just from their heartbeat. There is also evidence that obstruction of the veins that drain the head and neck, the internal jugular vein, less so the external jugular vein, can get extrinsically compressed, and they don't drain as easily as they should. There's something called chronic cerebrospinal venous insufficiency people have pursued. There are, I was just having a quick chat with somebody in Australia the other day who was very much into this and believed that these sort of abnormalities contribute to POTS, P-O-T-S, orthostatic condition where you can't maintain your blood pressure to your head when you stand up. There's a lot that's not known about it, but people are starting to research it and to look more carefully for where the veins are compressed. When we do a TOS MRI, I always describe in great detail what's happening to the veins as they come back from the neck and head and the arm and thoracic outlet into the chest. We look very closely at that to try to define what each and every important vein is doing. And I think this is an area of growth for us in the future. So the vein doesn't drain correctly, you might get a whooshing sound. If it's kind of more matching your pulse, it might be more related to an arterial condition. So the relationship to TOS, which is what you asked, I do not know an arterial relationship to TOS, but the veins in TOS can often be compressed in ways that lead to this low-grade venous congestion. And that is sometimes associated with headaches, which are common in TOS patients, and pulsatile tinnitus, or tinnitus in general, is associated with some TOS patients. So I would get a full workup for tinnitus from your doc if you haven't already. Usually an ear, nose, and throat doc would handle that, or a neurologist. And then I don't know how you were diagnosed with TOS, but it's not 100% diagnosis by a clinical exam. So you might want to speak to us again. Come to the website, tosmri.com, go to contact us and let us talk to you in private. Thank you for the question, James. Main focus. All right. How is neurogenic thoracic outlet related to cumulative trauma injury of the cervical spine and upper extremities from working as a dental hygienist? So there are some jobs. Thank you for the question. And thank you for clarifying too. There are some jobs that put people in unusual postures for extended periods of time. Sonographers get lots of upper extremity pain problems. And while they don't call it TOS in the radiology literature, because we deal with sonographers all the time, we're working on this with them, but I would probably call it TOS. Patients, we've heard of this from dental hygienists before, and other people, even people with non-ergonomic workstations. So having an ergonomist or an occupational therapist help out is probably a part of it, but this is something to pursue so you can try to assume the best possible position while you're, it's not an easy job. I know I had my first wife was a dental hygienist, and it's a tough, strenuous job physically as well as mentally. So I would have somebody help review your job position and your posture, and maybe arrange some breaks and try to assess what postures are in that could be improved or corrected. I hope that's helpful. Carolyn, ASMR. Can NTOS be caused by rounded shoulders? That is an interesting question. I'm going to say this. The answer is clearly yes and no, and I hope that's helpful. No, I'm partially kidding, but it is yes and no. So what happens is we believe that whatever instigates thoracic outlet syndrome, particularly neurogenic thoracic outlet syndrome, the type where the collarbone and the rib are too close together. In these cases, Carolyn, we believe that patients respond by guarding or protecting against the painful situation. So if it's tight over here between the collarbone and the rib, you kind of bring your shoulders up a little bit and you bring them forward a bit and you bring your chin forward. And that makes a lot less pressure on the brachial plexus. Problem is that you're shortening the muscles in front and lengthening the muscles in the back of your shoulders and neck. And the muscles, when they're short, they like to stay that way. So it now makes it more painful. The muscles get tight. Now you have to do it even further. And it's a vicious cycle that you have to break. Now, it's possible that some patients, due to other conditions, they bring their shoulders forward. Let's say me sitting on my laptop and I'm always doing this, and then they can initiate the process, which then aggravates it, and they have to do the same thing, move their shoulders farther forward. So I would consider the rounded shoulders more of a sign of what's going on rather than a direct cause. But it may be like the chicken and egg question. It may be irrelevant which one is first. If that goes together, I hope you have a good person diagnosing you and assessing you for neurogenic TOS. So thanks for the question, Carolyn. Herb is going to give us another question here. All right. So, first of all, I want to thank everybody for attending. We really appreciate the support from our viewers. Again, we'll remind you, find us on social media at TOS MRI. We could use all the help we can get to raise awareness for the next patient down the road. Like this video, please, and hit the subscribe button. And then keep an eye out for our schedule coming up for our next talk. Herb, do we have our next talk scheduled? Probably not. So we will alert everybody through our subscription and through that alarm when our next talk is coming up. Also, our website is www.tosmri. We're doing some updating recently with some more information, some organization of information, and we hope you find it helpful. We'd love to get comments on that. And finally, if you want to contact us about individual questions for yourself, we do that in private in a secure form because of HIPAA and because it's the right thing to do. And so you can reach out to us on our website. Just go to the top menu all the way to the right. There'll be a button that says contact us. And our staff is very friendly. They even treat me well when I don't deserve it, but hopefully I usually do. So again, this is Dr. Scott Worden, the TOS guy. We're always happy to talk about TOS. I'm happy that you all joined us today, and we look forward to seeing you next time.